It's time for the CareCast, brought to you by the Knowledge and Evaluation Research Unit at Mayo Clinic. I'm Victor Montori, your host for this CareCast, and today we are in for a treat. Arlene Bierman, Dr. Arlene Bierman, is with us. She leads the CEPI, which is the Center for Evidence and Practice Improvement at the Agency for Healthcare Research and Quality of the United States government. Arlene is a general internist, a geriatrician, a health services researcher. Today, we're going to be exploring a range of topics in the fashion that we have followed here at the CareCast. But we are very lucky to have you, Arlene. Thank you for joining us today.
Oh, hi, Victor. Thank you.
So the first question that we always ask in these things is, how does one become Arlene Bierman? What's the journey like? Is it something you chose to do when you were little and you followed a straight path, or has it been a convoluted path, a mixture of choice and chance?
Yeah, well, I could say I've taken the scenic route, which has been nice. So I was born in Brooklyn, New York. My family was living in the projects at the time I was born. I grew up working class in Queens, and I was the first person in my family to graduate from college. But I was very lucky, having been born in New York City, where we had access to, good public schools at the time. We had museums and the Philharmonic in the park and great libraries, Shakespeare in the park. So I had lots of advantages, even though our means were pretty modest. So anyway, that's where I came from.
And how did you end up where you are now? I mean, did you choose to be in government? How is that? How did that happen?
So I've done many things across the course of my career. When I graduated from medical school, I actually went back to my old neighborhood in Queens, where I practiced for over a decade in the public hospitals of New York City. I ran the Department of Ambulatory Care there and a primary care internal medicine residency program. I've also, I'm working in government now. I did a stint in government before, and I've also been an academic. So I've taken a couple of different paths in my career.
And what has motivated those paths? Is it just opportunities that you chose to take? How did you navigate all those paths?
I think one thing went into another. I always wanted, I clearly, returned back to New York City to take care of people who were, underinsured, poor, uninsured, because that's what motivated me to go to med school. And then I quickly learned that, there's all kinds of challenges within the health system. So there was a lot, I wanted to contribute to fixing them and making care higher quality and more equitable. And I think, just being open, willing to take chances, and, seeing what comes along is how I got here.
Yeah, many people say that they went to medical school to help people, but then a lot of people must have forgotten that, right? I mean, how you didn't?
Yeah, well, I think, there's powerful, socializing forces in medical training. And I think it is challenging to resist them. But for me, it was always key to stay, close to who I was, and, maintain certain values, and knowing the reason I was going into medicine, which was really, it was to help people, of course, but also to help communities and help increase, access to care for people who were challenged.
Was the bedside not enough to do that?
I think it's important. It's important, and I love practicing, and it was really pretty cool. I working in Queens in my old neighborhood. I would run into my patients I lived in the neighborhood, and I would run into them in the fruit stand. I remember a diabetic saying, "Look, I'm buying with his wife. Look, we're buying vegetables vegetables and fruits. And I said, oh, that's great, you know. So yes, I think there's a lot of rewards in the practice of medicine, of being able to help people one-on-one, but also very enriching, learning people's stories and learning a lot about life. One of the things we did, it was very interesting. We were asked to do quality improvement, which I knew nothing about. And, you know, as a team, we decided, okay, what is the biggest problem? And we were all tired of seeing women come into the clinic with late stage breast cancer.
This is in Queens.
This is in Queens. Half of our patients were uninsured. You know, then the rest were a mix of Medicaid and Medicare. And we actually did find out there were a sizable number of people who had private insurance and they just thought we were good doctors. So they didn't tell anybody. So they came to see us anyway. But we didn't collect because they didn't tell us they were insured. So we fixed that. But with it, but our patients were from all over the world. It was the most ethnically diverse zip code actually in all of the US, from 110 countries. And lots of people also who were not exposed to preventive medicine before. And we all worked together. We worked, you know, with the clinicians and nurses. We had standing orders, why this was important. We had videos in multiple languages and handouts in the waiting room. And within a year, we had rates of mammography screening of 80% higher than the best HMOs in this very challenged community. And I think at that time I realized, well, maybe we didn't do it in a research way. We just kind of thought about what would it take to fix this? And sort of at that point, I decided I wanted to go back and get research skills and learn how to do this in a way that was more generalizable.
And where did you do that?
At Dartmouth. So I got
that's an okay place, right?
Yeah, it was all right. I got a master's in health services research, and I learned how to work with big databases.
And how was that experience of going from, I mean, many researchers, sometimes to a fault, seem disconnected from the realities on the ground, particularly health services research that see the world through databases and through the data, but having had the experience of being on the ground with patients and with clinicians, how did the experience of going from the ground and trying to improve things on the ground to the, you know, the distance of the classroom and of the database, how did that fit you?
So, you know, that's an interesting question, Victor. It was a marvelous opportunity. I learned so much, and I found that I had a passion for working with big, you know, databases, secondary databases, which I didn't know before. But I should say, and I went in there with a very clear goal of why I wanted to learn the research skills, and it really was, how do I do research that could really advance health equity and improve access to care and quality of care for people who, you know, I think the COVID epidemic has really brought home how disparate our health system is. You know, we have the best care in the world, and then we have the worst care in the world in the same country. I should say that, you know, when I was studying at Dartmouth at that time, I was interested in health equity, which has become very trendy, a lot of attention to it. Nobody was interested in it at that point. And
how come? I mean, how could they have been so interested?
I think it's the work of a lot of people, a lot of researchers who in aggregate have educated people and have documented the magnitude and the relevance of the problem. And it was interesting. I was thinking about becoming a researcher and kind of a little discouraged that nobody was excited about the questions that I wanted to research. And I actually listened to an interview with Martin Scorsese and Hollywood. And he said, well, you know, I'm from a different place and my movies are about that place. So I just said, okay, I'm from a different place and my research is about that place. And you know, I've continued to really, having spent over a decade, you know, in the trenches, I think still informs my research. You know, I am so glad that I've had that experience.
And I presume you discovered that there is plenty of room for women in academia.
Oh, let's not go there.
Oh, come on, we have to go there. I mean, it is a major challenge, isn't it? I think it's very hard for women to have successful careers as judged by academia, successful careers in academia, right? I mean, was that evident at the time you went through it?
Oh yes. I think there's lots of bias, but I just really kept my focus on what I was doing and why I was doing it. And, I knew there was bias in the world, right?
Yeah, yeah. Well, you were experiencing it from the clinic.
Yeah.
How did you? So once you were armed with those with that research armamentarium, so to speak, did you go back to Queens?
No, so this is funny. I did. My plan initially was to, get the research training and go back to Queens and keep doing what I was doing. And then kind of got derailed along the way. I think, well, there were two things that happened. One was New York changed a lot. I was doing in Queens, we were doing community-oriented primary care, things that people are talking about now. So I think it's, going back to the future.
Yeah, the pendulum. Yeah.
My first grant was from the United Hospital Fund, which really developed a strong partnership between the hospital and community-based organizations in our community. We were working on setting up family health clinics as satellites. I actually established the first family health clinic in a New York City public hospital. So we were doing all kinds of cool stuff. But the governance in the city had changed, where that wasn't as well supported. And actually leaving New York, and I had two young boys at the time, I realized that there were better places in the world to raise kids. So I ended up not going back. Yeah.
And where did you go?
I ended up going to AHRQ. So I spent a stint at ARC, and I never ever thought I would go to government. So I think it's like kind of just being passionate and being curious and being willing to take risks. I actually had been offered a job as chair of preventive medicine in a major medical school. And a good friend of mine said, and I had turned down ARC. And a good friend of mine said to me, "Are you crazy? You think you're going to run a department, teach, see patients, and build a research career?" And at that time, I was offered an intramural research position at ARC. They had those in those days. They said, "Take that, to get paid full time to do research, And actually, it turned out to be one of the best jobs in my life, and I loved it. I worked, I actually had two hats when I was at ARC the first round. I was a intramural researcher, focused on both health equity issues and disparities, as well as on, patient-reported outcomes, functional health outcomes in older people with chronic disease. So it's kind of split. But I was also a senior advisor on aging to John Eisenberg. And I worked very closely with him. And he just taught me so much and just made me think I could do a whole lot more than I ever imagined, that I had not thought about doing.
It's interesting. Every time I've met anybody that met John Eisenberg, which I didn't get a chance to meet, everybody that talks about him speaks highly of him as somebody that was able to build HCPR and ARC, and to do so with enormous mystic and great capacity for mentorship. Is that an accurate depiction?
Oh, absolutely. I wrote a paper with him I called it the paper from hell, on collecting racial and ethnic data that was eventually, published in Health Affairs. And he would give me, drafts back, correcting my grammar and my commas. And I felt so embarrassed, but he taught me how to write. And he taught me how to write about sensitive issues, because at that time, collecting racial and ethnic data wasn't, acceptable like it is now or assumed. And he taught me how to write about issues that might be sensitive in an objective way that could, educate people why it was important.
Listening to you, one gets the impression of local and regional government and then federal government having roles in giving people opportunity to get exposure to culture, to services, to care, to education, and government as a force for innovation and advancement. Uh, we don't have that picture of government every day, but you seem to have experienced it firsthand.
No, and it's like, once, now I'm here, nobody would know like where I came from or my background. And I think about that. Like I grew up in a really golden age of New York City. And the access we had, to culture, but also, like free tuition in the universities, as well as, one of my first jobs in healthcare. I was working the midnight shift in a fast food hamburger restaurant underneath the Triborough Bridge, and I got an Urban Corps job. And with that job, I was able to work. I worked as a phlebotomist, a lab tech, a respiratory therapy aide. And that actually, kind of reaffirmed my motivation to go on and study medicine. So.
Yeah, and then in your first stint at ARC, bringing attention to important issues, innovating science about, how to write about these issues of, for instance, race. It's government employees at the forefront of science. Sometimes we forget about that.
Yeah, no, I mean, I never in a million years like thought I would end up in government, but I don't know if you read The Fifth Risk by Michael Lewis.
It's on my list.
Well, anyway, I kind of was annoyed at the book. Like he goes into, agriculture and, some of the other science, energy, and he finds all these amazing scientists doing all this amazing work. And it's like, well, you should know that's what government can do for people. And and I mean, when I look at one of the things I love working about at ARC is just the smart people who are there. And people come to ARC and come to government because they're passionate, committed, and they want to make changes and they want to contribute to change.
Bright brains with a heart in the right place. I for full disclosure, Arlene was my boss at ARC. I had the opportunity and the pleasure and the honor to be a senior advisor for ARC for a few years, and that was my experience, which is the opportunity to interact with bright people that wanted to make a difference, and that they had chosen a government opportunity to actually make that difference. It was extremely inspiring, and they were, of course, working under your leadership, Arlene. So that was very inspiring to see. If you were to think about and we're not yet finished with your trajectory because that was your first time at ARC, but if you were to think about what is the primary value that animates your choices in your career, what would that primary value be?
I think I've alluded to it. It's equity. I mean, I think the consequences of income and racial and ethnic inequity in our country is really in front of, we can't ignore it anymore. But that, and the hardships in people's lives that are unnecessary, as well as the loss to society of all these people who could make amazing contributions, So I think, just and feeling part of a community. As a researcher, I really felt strongly that I was part of a community who were publishing, who were writing about equity issues, writing about disparities, writing about better ways to deliver care, and even to change things. It's being part of a community who could put all this evidence together that eventually adds up and makes changes.
Yeah, it's a beautiful community. But it's been, correct me if I'm wrong. I have a bit of a weird perception of the health services research community. I think on the one hand, it's described very well if we were to think of people like you, but there's also another set of people who perhaps are newer to the field, who are enamored with the data. Some of them, in fact, carry titles like data scientists and so forth, and they're dealing with massively large data sets, and they are able to do incredible feats of alchemy with them, with algorithms and computations that are hard to follow sometimes. And it just I wonder if my John's view of that is similar to perhaps the old expression of armchair epidemiologists, right? there's a bit of a disconnect between the reality that is perceived through the cloud of data and the reality that you've seen, for instance, in the streets of Queens. Do you have a similar sense of that, or do you are more, are
No,
you more optimistic?
no, absolutely. Uh, yeah, I think that, first of all, I actually once wrote a book chapter on how to analyze secondary data. So I am a total data nerd, and I totally appreciate the value of data. Working on a project at ARC on developing algorithms to identify frailty, and so in claims and EHR data in partnership with ASPE. So this is something I enjoy, and I see the power and the value. I think we do need data. But when I wrote that chapter, the first thing I said is you have to start with the question and not with the data.
Mm.
And you really have to understand what the data is representing. So, I think we can there are people doing that, and I think we just need to encourage that. And I think, taking the data in isolation without understanding what's underpinning it can sometimes lead to misleading conclusions.
Yeah, and with the spirit of your primary value, there's also this increasing recognition that the data that is then used to answer questions, the data itself was produced by individuals and systems that may have significant biases in discriminatory practices that then manifest in the data and then carry on into the research, right?
Yeah. So I don't know if you've another book I highly recommend is a book called Weapons of Mass Destruction. I don't know if you've heard that one, but it really talks about all the pitfalls of using data without critically understanding what, the biases in it and what it's doing.
Yeah, and this year's Academy Health keynote spoke about the other challenges, which are not mathematical or not, algorithmic, but have to do with the, further discrimination of folks on the basis of who contributes and how they contribute to the data, and who decides what data then gets to be included in analysis. So there is a threat to equity now through data, which is
and I'll tell you a story about that. I think more and more we need mixed methods to really validate what the data is telling us. And we didn't talk about my stint up at the University of Ontario and in Toronto.
Time for it.
I was a PI for a large study that did a health equity report for the province of Ontario. And we used a partnership, community engaged approach in the context of this big data project. And we got people together to, get input. We both had experts, like technical expert panels, but we got the community to tell us what we should be measuring and help us select our indicators. And when they looked at our access indicators, they're not surprising. Everybody knows them, avoidable hospitalizations, barriers, difficulty getting appointments, like all the standard access measures. And they looked at us and they said, yes, you should report these. And they told us which ones they thought were more important. But they said, but you're missing our experience. It doesn't capture the challenges we have getting care. So in response to the community, we actually did a qualitative study of barriers to care of women from different disadvantaged groups in Ontario: immigrants, racial ethnic minorities, First Nation, disabled women, LGBTQ women. There was a huge literature out there. I worked with a PhD student and her supervisor, who were qualitative researchers, learned a lot about qualitative research. And we ended up with two papers, one on all the barriers people, experience. And then we found one on agency that we don't think of, that everything that people do to deal with the system and how they overcome it. And some of those strategies are good and others are not so good. But then when we wrote up our indicators, when we ran all our data, it provided context to interpret what we were seeing. So I think that's really, really important. And also, sort of checking back, that's a qualitative thing, but even quantitative things. I was invited to present our results up in Muskoka, Ontario, which is where it's a cottage country, and, to the local health integration network. And they did terrible on a lot of the measures. They had more readmissions, more avoidable admissions. And I said, could this be right? I thought of it as like, affluent cottage country. And before publishing, I went up there, I showed them the results. I said, does this resonate with you? They said, absolutely. You know, there's a lot of people here who are disadvantaged. We don't have, you know, good coordinated care, and we have holes in our health system. But so I do think it's important, even if you're working with big data, to go back and, you know, validate it with the community.
Yeah, that seems to be a lesson that needs to be learned and relearned and relearned and relearned. In our unit, Arlene, we have three values: patient-centeredness, integrity, and generosity. Any of these three strike you as closest to your heart?
That's so hard. It's like choosing between your children, but I think they're all really, really important. But I would pick patient-centeredness.
Why would you do that?
Because I think if we have to have an effective healthcare system, we need one that is centered on patients, who they are as people, their lives, what their needs are. And then I think you can't do patient-centeredness without generosity and integrity. So maybe I'm cheating a little.
Yeah, I think you are, but I think you're right as well. It turns out that everyone we've asked that question ends up on some variation of the fact that it doesn't matter which one you choose, you need the other two anyway. Otherwise, you're dangerous. Tell us about going to Canada. How did that come about, and what was different about that experience?
Oh, it was a wonderful experience. So I should say my mother is from Montreal. So I had a Canadian connection. You know, I used to spend summers in Montreal with my uncle and my grandmother. So it wasn't, you know, a strange place. I think Toronto is a great city. And to me, it was like a livable New York, where I could live midtown, raise two kids, and afford to live there. So, you know, it had a lot of draws. Yeah, I ended up going to the University of Toronto, and I actually had an endowed research chair. So I did a stint as an academic, and as a, you know, tenured full professor with an endowed chair, I came back to ARC. So, you know, the choices I make are not the choices I think many other people would make.
Yeah, but I think those are the choices animated by what you say, is knowing what matters to you,
Mm-hmm.
and where you might make the biggest difference. Coming back to government from a tenured professorship position is almost like you're pathologically looking for discomfort.
Yeah, and people thought I was crazy, but I love, you know, you know, like I say, well, you've been, you know what it's like where we are. I get to work with a lot of smart people, and I get to really, I think, make a difference in, you know, in the research that's done across the country in improving care.
Absolutely. If you were to think back, I mean, it sounds like you've had phenomenal collaborations with your colleagues in Queens, in the clinic, and with the communities there, perhaps with the academics at Dartmouth, perhaps with Eisenberg and other colleagues at your first stint at ARC, your colleagues in Canada. You describe a big collaboration there. Now your colleagues at ARC. If you were to think back, what has been your favorite collaboration, your best collaboration?
I'm going to cheat again and give you two. So, I think in Ontario, I was you know, I mentioned before, I was a principal investigator of the power study that presented a developed a health equity report for the province of Ontario. And I actually had 60 co-investigators who had expertise in the different, you know, reports that we did. But we also partnered with, like, you know, the system, the Ministry of Health, the local health integrated networks, you know, patient advocates, community organizations, public health. So, and it was exciting bringing all these people together to have conversations. So it wasn't the data so much or the findings. It's like, what is this telling us? And what does this mean for the health system? And, you know, when we started the project, I insisted on, like, publishing the data at the regional level. And people were very nervous about it. They had just created the local health integration networks. And, you know, we don't know if you should do that. People are going to get upset. And the way we framed it is, no, that you just created them. They need to know their baseline. They need to know where they are so they can do better. And we actually worked with the LINs. We showed them their data before we published it. We gave them our SAS code so they could run and track the indicators they wanted. And it worked out well, you know, so I think you have to kind of be creative and how do you do these things in a way that's positive. So that was a great collaboration really broadly. I could say now at ARC, I'm just really excited about my e-care planning project. So we have funding from ASPE, which is the Assistant Secretary for Planning and Evaluation, which gets a portion of the Peace Corps Trust Fund. And the purpose of this funding is to develop infrastructure to better do patient-centered outcomes research. And Victor, you know, my passion for improving care with people for multiple chronic conditions, but one of the barriers is you don't know what everybody else is doing, and you lose a lot of what's happening to them if they go to different systems, different practices. So the real need for like an interoperable care plan that shares data across providers, that's accessible to patients. And it's been a great collaboration. We're partnered with NIDDK, we're developing it together. It's interesting, NIDDK started working on a care plan for people with chronic kidney disease. And I was working on one for multiple chronic conditions, and they quickly realized that, hey, these people with kidney disease have multiple other things. So they need, and you know, and they have a lot of the more of the technical know-how than I did. So it's a great partnership. So we're doing that together, but we also have multiple federal partners involved. CMS, VA, Indian Health Service, ACL, I won't go on and on. So the federal team, you know, in terms of collaborating across the federal government, understanding how this could inform federal programs. But beyond that, we have technical expert panels who are helping us choose the data elements. But we've also partnered, HL7 has adopted us, so that hopefully that these will be the standards to allow information to exchange interoperably. And what we were worried about is there's a lot of movements on care plans, and it'll end up like EHR, where it's the Wild West and they don't talk to each other and they're all a little different. So we thought if we could get at the head of the game and develop the technical standards, people could use these and build on them, and maybe we could have interoperable care plans one day. So that's, you know, that's a great collaboration.
Yeah, I mean, so people listening to this or watching this are going to go, wait a minute, these are federal agencies working together on this. What world is this that we're talking about? That is phenomenal. So Arlene, what does it take personally to foster these collaborations? I suspect that's not the default. That it takes substantial commitment to the project and effort. And I mean, what does it take?
I think it's willingness to listen and to share. And other people are sharing with us too. So for example, you know, CMS had worked on developing a care plan for electronic, you know, long-term care services and supports. So they're willing to give us what they've done so we could incorporate it in ours. So I think making it a win-win, understanding what people's problems are, understanding how you could develop this in a way, you know, I think we're going to have a better product because we're going to know what our partners need in the care plan to make it work.
Yeah, so you have a diversity of scientists, a diversity of collaborators, communities. Are users involved as well?
Excuse me?
Are users involved as well?
Yes, they are. So we have, you know, a contract. We have, well, users are involved in a couple of ways. We've included patients on our, you know, technical expert panels to talk about the measures and what they want to share about themselves. But we also have a contract with RTI and OHSU where we're doing focus groups and user testing. And also the developers are doing use. So yes, we're using user-centered design to be able to develop this plan.
Fantastic. We are getting questions now from some of the folks that are here, and I will select a few of those for us to consider as we go forward. But one of the things that is coming strongly here in our conversation is that government is a potentially great place for a young scientist to develop. And so the person asking the question says, would you encourage young scientists today to pursue careers in governments? Why yes or why not?
So absolutely. And, maybe I planted that question because I'm recruiting. So if anybody wants to come work with us at ARC, we have a number of positions. So just reach out to me. But also, what I want people to know is that whatever at different phases of your life, you find the place where you can do the best with what you have and what your interests are. So that's what I tell people. It doesn't preclude going back into academia. I was in practice, I went to government, I went to academia, I'm back in government. So I think, and it enriches your experience. And I can tell people from, working at ARC the first time, I learned a lot on being on the funding side. So I was really great grant writer when I went back to academia because I learned how grants were evaluated, why things were funded or not. And so there's a lot of skills you could pick up also that you might not appreciate before coming.
It's interesting. When I was considering a position in government, I was told by my advisors that once you go to government, you never come back to academia. So your clarification, I think, and your demonstration in your own life stands as in contradiction to that ill advice I got. And then somebody asked the question, are there ways of contribute and engage in government work without moving to Washington?
Well, yeah, yes and no. So that's hard. I mean, I wish government was a little bit more flexible in terms of, distance working, but we have different ways people come work with us. We have fellows who come and spend some time and rotate with us. We have people sometimes are able to come on an IPA, which is, part of their time spent with us. So I think there's, and then there's participating, we're very, ARC is very committed to engaging with stakeholders, and we have expert panels and other ways of kind of contributing your ideas. So there's ways to kind of get engaged with us without necessarily becoming a Fed. So
in some of the most brilliant health services researchers also work for the local and state governments, right?
Mm-hmm.
So that might be another opportunity, is to engage with the local and state government, local Medicaid agency. These are all there's other opportunities to work in government that is not necessarily federal government, but it's state government. I guess that's another option.
And it's, and I think the advice I would also give is, find out like what question are you asking and why, and if you get an answer, it's like the big so what question. And I think, a lot of my research questions have been informed. I've had like a nascent idea, but really having it refined by, consulting with the people who you hope to use your research, so that it is answering a question in a way that helps them.
Arlene, this series of CareCast is in the context of our program of work of Care That Fits. How do we help patients and clinicians form plans of care that make emotional, intellectual, and practical sense to them and fit in their lives? And then how do we help patients work at home or at work or wherever they're developing themselves to make sure that plan of care follows them, particularly patients with chronic conditions, follows them through life in ways that are perhaps minimally disruptive. Yesterday or the last couple of days, ARC hosted a multidisciplinary international meeting on multiple chronic conditions. And I know you were an active participant and leader in that meeting. What does it mean to you today to make care fit?
I think the care we have doesn't fit, right? And it doesn't fit for everybody. It doesn't fit for especially people who have multiple chronic conditions, which is the norm. Jane Peterson, who was working with us on helping us organize this meeting, said she told her husband, who's an intensivist and pulmonologist, what she was working on, and he goes, "But isn't that what everybody has?" And I said, yes, and that's the whole point. That people see different providers, different settings, get fragmented care, and we treat one disease at a time, and not the person with the disease. And to me, is care that fits is taking care of people not their diseases, but their people and who happen to have different diseases in the context of their lives, and recognizing their values, preferences, and goals in shaping a care plan.
Oftentimes that is unavailable to clinicians, either because of clinicians' lack of curiosity or skill to pick up the information that one gets from asking those questions and integrating them into care. But it sounds from your experiences both in New York and Toronto that you had tremendous exposure to people from all over the world. How has that shaped your perspective about making care fit?
Well, I do think that we have to change, we have to totally change care. And I think it's a culture change in medicine. I think we have to change how we organize and deliver and pay for care. So I don't think it's easy. But I can tell you when, most of my work was clinical and I was sitting in the clinic in Queens, everybody who came into my office in an afternoon literally was from not only a different country, a different region of the world. And I would just sit back and ask, I said, like, what did you do back home was my standard question. And I would get these amazing stories, and I was able to relate to my, patients in a way of having a sense of, heard incredible stories of, people who had to leave, were engineers and had to leave for political, reasons, and were now driving a cab in New York. And but I didn't see them as a cab driver, and knowing who they were and the disappointments and traumas, people who experience torture, like just having a sense, who is this person in front of you? And what are the things that have impacted their lives and their health, I think makes you a better doctor.
Yeah, we talk about taking into account their biology and their biography. And in your case, it was really biographical data that you were after when you were asking that question. Any of those stories stick to your mind to this day?
Yeah, no, there's lots of them. It's hard to pick one. I think, the one I mentioned who was a cab driver, who was an engineer and was asked to do some things that he thought he was working for, a government, input, and was kind of being encouraged to get involved in some corruption, and he would have no part of it. And he left and because he refused, he was being, threatened, and he left the country, and he was making a new life in the US.
Yeah, it is. There is something, and I don't want to put words in your mouth, but correct me if I'm wrong, but there's something somewhat romantic about some of the things that you're describing, particularly back in your time in Queens, in relation to having time to sit back and listen to stories, the opportunity to create a clinic, that is open to everyone, regardless of ability to pay, that is able to do so with high degrees of quality and commitment to care. Why does it feel, maybe it's me, but maybe not, why does it feel that is a world that is no longer with us?
No, we've lost a lot, but it wasn't so. There were a lot of things that needed to change back then. We still had the same pressure for volume. Visits were often too short, especially for complex patients. But I think, people don't realize if you know your patients well, it's much more efficient and you could do better care. And even if I got to know them over a series of visits, and that's why continuity, I think, is so important. And I do think we have to think about how do we redesign care. And I can tell you, I directed a department of ambulatory care at the hospital, and we did it was a big department. We did about 500,000 visits a year. And then I started getting volume visits from like prenatal clinics, well baby checks. And I said, I cannot see, my 90-year-old only Italian speaking woman with 5 diseases in a wheelchair with an amputation in 5 minutes. I can't ask my doctors to do that. But I found as we were pressured to see more people faster, quality declined. Because rather than understanding what the issue is, what's going on, working with people on, a plan of care that they could live with that would actually improve their health, you're more pressured to make a referral, order a test so that you haven't missed something. So I think that there's huge value in redesigning care so that it is human. And what do we think? Like, I remember I would do a clearance, a surgical clearance for, some a geriatrician as well, a 90-year-old who needed cataract surgery, who had all these issues, right? And I would not, I'd get an office visit for doing this clearance. And then the, ophthalmologist got, thousands of dollars for taking out the cataract. And then afterwards, any issues she had, I was the one managing it, right? So we really do have to think about how we allocate resources within healthcare, and why can't we allocate resources to do better primary care? I think it's worth the investment.
Yeah, there's there is a connection between continuity of care, unhurried conversations, care itself, and then care quality and improvement of outcomes. And Mark Linzer, who I know demonstrated in Hennepin County how the slowing down the clinic had an effect of maybe creating a bit of a waiting list that went up first, but then as patients got their issues addressed in the first time, correctly, they didn't go back to the back of the queue and continue to put pressure on the system. They went on to demand less healthcare. So there is that, right?
Yeah, I'll give you two great examples of that. I remember one of my patients who was, in her late 50s. She was overweight. She had, type 2 diabetes and hypertension. She was depressed, very common. And taking the time to ask her, explaining that, maybe she could get off some of her, medicines if she lost a little weight and was more active, which we, sometimes see as futility, but working with her, what do you like to do? And it turned out she liked to dance, and she took up ballroom dancing. She met people, so she was socially engaged. She lost a lot of weight, and she eventually came off all her meds. And to me, that's a success story of medicine. But that takes time and relationships. Another patient of mine was a retired truck driver. Again, he had multiple heart attacks. He had end-stage COPD. He probably smoked in his truck. And he was one of these people who was readmitted every week or every month with, decompensated heart failure or, COPD exacerbation. And, it took a while, but understanding who he was, who his life, so getting him on a good regimen, one that he could manage, controlling his disease. But the biggest problem for him was he rented a room on the top floor of an old house that was very dusty and moldy. And that was his, no matter what he did, unless that changed, he was not going to be stabilized. And actually working with the social worker in the clinic, we had social workers, we had liaison psychiatrists, so none of this is new. The social worker was able to get him into subsidized housing, and he spent about 1.5 years without having an admission. So, so I think there's values to the system and getting it right and allowing people to have the time to understand why are people in the state they are and what can you do to reverse it.
Yeah, as you know, I'm very committed to this notion of shifting the aims of healthcare organizations that seem very committed to their operational efficiencies, the pursuit of value, and value to whom. At the end, unfortunately, it is a bit of a zero-sum game, and when the resources are tight, what you've described in terms of the churning of the patients because of the shortened amount of time with them, it's a universal phenomenon, and it occurs in systems that allow for-profit healthcare, but it also occurs in systems that are publicly funded, and where simply by decisions of austerity measures, the system is severely underfunded, and so the final pathology of care, if I may, is this churning of patients, which is cruel for patients because they're looking for care and they're not getting much of a choice. But there's also pretty cruel for clinicians because you don't get to care for them in such a narrow window.
Yeah, no, and I think, I was fortunate to have like the window of being able to practice when the pressures weren't as great. There certainly were pressures, but not as great as they are now, and see that transition and feeling like it was actually harder and harder for me to practice in a way that I thought was effective and valuable. And maybe, who knows, if the system hadn't changed and was different, I'd still be back in Queens, happily, practicing medicine. So.
Yeah. We have a couple more questions that relate to career, and one of them is has to do with as you pursue a research that is participatory. Um, how do you um, how do you find what is your so there's a lot of PCORI, for instance, has been being very active at the moment with trying to engage stakeholders and patients in research. People struggle with this. Who are these people that get to participate as stakeholders? Who are these people that have the time and disposition to actually take part in research as patient partners? Do we have equity issues in that patient? What are your thoughts about the state of patient engagement or involvement in research?
Well, first of all, I just want to say, absolutely how critical that is. And in order to, really inform your questions, inform what you're asking, I think we do need, engagement of people or patients in that research. That being said, yes, it has to be real. You have to think about who it is, where they're coming from, why they're involved. And I think, that's the advantage of being engaged in your community, because then you could really, identify people who are users, who you're serving, who can actually, so I do think people need to be cautious of, not just, it's not like a checkbox in an EHR, you happen to have a patient, but what is the relationship? What are they representing? And what can they bring to the project? And diversity, absolutely, to make sure that, different patient voices are captured.
Do you see a time where research funding agencies will fund patient-led research, research that where the PI is a patient, not an academic?
I don't know. I really don't know. That's a great thought. I do think it's a time for us to really think, not only what research questions, I always thought like research is what matters in research is not only what questions get asked, but who gets to ask them. So, whether that's a partnership with patients, whether it's patient-led, but I do think we need to start rethinking in a lot of ways, like how do we do research? How do we keep it rigorous and, make sure that we're doing good science, but really open it up to a lot more different perspectives.
Yeah, it's and who gets to judge whether the research is worth funding, right?
Mm-hmm.
We have the same problem with review committees, where again, PCORI has been able to expand the review committees to include patient representative and other stakeholders, but has had to deal with issues of training them and so forth, and again, issues of representativeness versus advocacy. So many of the folks initially that walked through the doors of PCORI were advocates, patient advocates, and
Yeah.
they had an agenda, right? That which was not to judge quality of research and pertinence of research, but it was the agenda of their disease or their condition.
Mm-hmm.
So it was complicated, but it sounds. I mean, if your career is any way of looking at this, that you're rarely slowed down by challenge. That seems what is inspiring you today? What is next for Arlene Bierman?
So well, you attended our multiple chronic conditions summit. I would like, if I have a chance to implement that agenda that comes out of that meeting, I would be in heaven. I think that would be exciting. That would be great. But I do think about like what comes next for me, because I've made so many different jumps, having worked in Canada, I'm very interested in cross-national comparisons and what we could learn internationally in healthcare delivery. Because the other thing I learned in Canada was that very different systems at the point of care, the problems are all the same. So I would like to maybe do some work on global health related to aging. But on the other hand, I could see getting very micro again and going back to a safety net system and really working on population health. So want a very local or very global, I'm not sure. But for now, I hope I get a chance to stay at ARC and do our multiple chronic conditions agenda.
Do you think medicine today is a career that young people should consider seriously?
Yes, yes, absolutely. I think, there's lots of challenges, but it is so rich. First of all, I mean, I still enjoy, medicine and understanding the body and understanding diseases, but you could just take so many different paths with it. And I think the way, hopefully we'll be, like we talk at ARC about not only the science of cure, which like 21st century cure, but the science of care. And I think that's developing. And I think there's a huge opportunity to really figure out how do we organize and pay for care in a way that makes a difference in people's lives and as well in population health. And I think, there's also, you might not know this about me, but in addition to my fellowship at Dartmouth, I actually did a fellowship in community and preventive medicine. And I've been living in two worlds all my life. And I think there's a great opportunity to bring together public health and clinical medicine. So I think the opportunities are enormous. So it's challenging, it's not easy, but if people know why they're doing it and what they're doing it for, I would really encourage people. And I love mentoring younger people, going through medical school or residency.
Arlene, we are coming to the end of our conversation, but it just occurred to me that, we have a generation of future physicians, nurses, therapists, pharmacists, future researchers, research leaders, people who are going to lead research agencies, funding agencies, who would have as part of their biography having lived through the COVID pandemic and through this time in general. What have you learned so far from what you've seen in COVID?
Oh, what a tragedy. But I do think it's an opportunity. I think all the mistakes that were made, I just feel for all the people who've been affected, all the family, everybody who's lost loved ones. I mean, the magnitude, I don't think we could even get our hands around the magnitude of the tragedy of COVID. But I do think at the same time as all the people who've stepped up, the practices who went to telehealth, overnight. And I think, just looking at what COVID is, brought in front of our face in terms of how the system doesn't work, the inequities in our system, I think there's more attention being placed on the need to focus on public health. But hopefully we'll see also the primary care system could be so critical, not only in, taking care of people with COVID who are not as seriously ill, screening, testing, but also keeping people well and mitigating risk who are living with diseases and how critical that is, and reaching out to communities at high risk for COVID. So I hope that we take this as an opportunity to really learn a lot of lessons and say, how can we change our healthcare system to be better?
Phenomenal, Arlene. I've learned a number of things from COVID as well, but one of the things that I think I've learned that is important is that scientists working within the government have made an enormous contribution to the health of people at a time that's very difficult, and in a world that has and remains quite confused about the role of science. The fact that we have at ARC someone like you is an incredible privilege, and I want to express my gratitude for your service.
Oh, thank you. Thank you.
I think it's absolutely essential. Thanks, Arlene, for participating in our CareCast. This brings our program to an end, and I would like to invite everyone to join us for the next CareCast and to join me in expressing our gratitude to Arlene. Please stay well, be careful, and see you next time.
Bye-bye.